guidelines, it is add-on therapy. It is the third add-on therapy. The first add-on therapy is LABA. After LABA, Eltras. Then after that, methyl-xanthines. Why? Because the therapeutic index is narrow and it needs blood monitoring to the level, and many things can cause side effects to appear very quickly. So it is very behind in the guideline. Many types of xanthines. Firstly, mostly now they use slow-release tablets to avoid the side effects. And it is the last choice after LABA and Eltras. It is the third add-on. And as we see here, it is used less frequently. The action, it has many actions actually. Bronchial smooth muscle in dilatation and relaxation, and inhibit the release of mediators from the mast cells. Side effects. There are many side effects: nausea, vomiting, restlessness on the brain, convulsions, arrhythmia, hypotension, and it is a routine to use methyl-xanthine injection inside the emergency, and the evidence say that methyl-xanthines by injection are the only commonly used asthma drug that can be fatal to the patients. So you can imagine how the practice is bad. You give the patient a fatal drug. So if there is a need, because in acute, I hope inshallah in the future, if you are alive, we will give you one single day for acute asthma. But this is not the time to talk about acute asthma. But you have to give oral steroids and you have to give another treatment, but you avoid injectable methyl-xanthines. It works for 12 hours and taken once daily nocturnal. It's a nocti drug. Usually it's taken in step 3 after trial of LABA and Eltras, and it is used less often because of the many side effects, in spite that it is inexpensive. Because of the very narrow therapeutic index, below this 20 milligram per liter, it will give no effect, and more than that, it will give side effects. And it is difficult to achieve plasma levels within this therapeutic index. It's very, very problematic to reach to that. Plus, that no two types of thiophenyls are similar in the action. So you have to read the manufacturer. And you have to have a blood monitoring for the level. If intravenous aminophylline is to be given, only it has to be given in the ICU by senior medical staff. So it's very clear to you now that methyl-xanthine are very behind. We are talking about relievers till now. This word is very important. In the acute attack, aminophylline is unlikely to result in any additional benefit to the administration of high dose of bronchodilators and systemic steroids. Systemic steroids, oral steroids. We prefer oral steroids over the injection of hydrocortisone. And we will tell you later, inshallah. If the patient cannot take oral steroids, yes, he can take injection of hydrocortisone. So there is no any benefit if you give this dangerous drug, especially if you want to give it by IV. There is no any additional benefit that you give it with this high risk over if you give bronchodilators and systemic steroids. It needs a blood monitoring. Amazingly, in spite of all what we said, it is an OTC drug till now. These are the relievers. We will start with the preventers, steroids. We say that in preventers, steroids, then we say other preventers. So it's very clear to you now that steroids are the first line preventers in asthma. But in spite of that, there is a lack of appropriate use. There is underuse of steroids. It's a very huge problem. And this is one of the major causes of the high morbidity of steroids, of asthma. Yesterday we talked very clearly about the high morbidity of asthma, and one of the major causes is the underuse of steroids. So there is underprescriptions and there is bad technique of using steroids. In spite, it's the first line preventer, there are two major problems: underuse and bad technique. Please remember, the main problems of using steroids. Firstly, bad technique. Secondly, bad compliance. Maybe the patient is not believing this is an important drug, or he is having misbelief that this drug will cause all the side effects. You have to discuss with the patient the concerns, and you answer him the concerns that this is a very, especially the inhaled steroids, that this drug will not cause many side effects and it can preserve your life. So you have to sit with the patients and discuss. The issue of steroid is very crucial in asthma. Or under treatment using lower doses of steroids. The patient needs, like an example, 400 microgram and you give him 100 or 200. And still, some of the doctors, they have phobia from using steroids and the misbelief of the patient. Very clear, in red, in spite that the steroids are the first line preventers and anti-inflammatory drugs. In spite of that, till now, there is underuse. And some of the doctors or patients have aversion to steroids. And, of course, inhaled steroid formulation having very low side effects in comparison to oral steroids. And when we come to oral steroid, we will tell you that there are two courses, short and long. Even the short course oral steroid is having a very minimal side effects in comparison to the long one. So, very clear, you have to concentrate on this issue a lot, because this is the golden rule of steroids in asthma. Of course, it is anti-inflammatory. It will work on eosinophils, anti-inflammation, mucus, but it will not work on smooth muscles. This is the work of relievers. We'll start with the inhaled steroids firstly. Inhaled steroids, you have many types of inhaled steroids. But what is important in this slide is the double effect. The meaning of double effect, that when you want to give this drug, like an example, fluticasone or mometazone or CFC-free inhalers, you have to give half the dose when you give beclomethasone. Like an example, you want to give 400 beclomethasone. If you want to give an equal drug or equal dose to that from fluticasone, you give 200. So, fluticasone, mometazone, and CFC-free inhalers have double effect. Sickly sonide is a new drug, Alvesco. This is sickly sonide. What is CFC-free inhalers? CFC is carbon, fluoro, CFC, I cannot remember the name. But this substance is found in the old inhalers, and it can cause a pore in ozone layer. And because of that, they remove the CFC and they call it CFC-free inhalers, and they put HFA, hydrofluoroalkane, in the place of CFC, and they call it CFC-free inhalers. And we will show you today, inshallah, in the lecture of delivery systems, what are the types of CFC inhalers, and it is very safe. While it causes problem to the ozone, you have to tell the patients it's very safe for human beings. The buff of CFC is slower than the buff of the normal inhalers. And that's why it is a double effect. Because if you use any drug in the, if you use any drug in a spacer, it will be slower than the other drugs. And this is why the CFC is having double effect. Hayakallah. Salam, hayakallah. Beclomethasone is the first. There are many types of beclomethasone, and also there are free, CFC-free. This is CFC-free, okay? And CFC now is starting in the market. Kuvar, this is Kuvar, this is autohaler, and this is CFC-free also. And they put HFA in the place of CFC. Budesonide is available in Pulmicort. Fluticasone is available in Flexotide. All these are types of steroids and inhaled steroids. Mometazone is available in Asthma. This is a new drug, Alvesco, sickly sonide. Safety. Low dose, it is very low dose. 200, 400 microgram. You compare it, like an example, to 500 milligram of steroids. So the difference is big. So it is a very low dose, and it is important for control. You take the lowest dose, which can give highest control. In adults, you can reach to 800 microgram without any problem. It can cause hoarseness of the voice, and you ask the patients to have gargling after the dose. Or you advise them to use the spacer, because this will let them to avoid the oral thrush. But higher than that, it can cause bone density, and this is more commonly seen with the oral steroids than the inhaled steroids, of course. Inhaled steroids are used in the step 2 in the BTS and sign, and usually it is used if there are a lot of exacerbations or the patient is using inhaled beta